serving as a clinical associate professor at Nova Southeastern in Clearwater, Florida. Before he was a professor in New York, and was also past president of API in 2000-2001. Most important thing happened during his tenure as a president. He reactivated the chapters in New York and New Jersey and Connecticut and made them as a pattern member of National API. I'm sure you know that now those chapters are very vibrant. Thank you very much for doing that, Dr. Naik. And without further ado, I will ask Dr. Naik to commence the meeting. Thank you, Dr. Naik. Welcome. Unmute yourself. Unmute. Dr. Naik, unmute, please. Vijay, can unmute Dr. Naik?
Can you hear me now?
Yeah,
Yes.
I can hear. Yeah, go ahead.
Okay. But today we have a very good topic, type 2 diabetes in Indians. And our speaker is Dr. Venkat Narayan. And in fact, he is a professor at Emory School of Medicine. He has done extensive research, produced a tremendous amount of papers and articles, and he has done a lot of work in diabetes. And in fact, Indians, we are sitting duck. In fact, develop diabetes, not only in India, wherever we have migrated, this has become a big, big problem. So Sudhakar has brought up this subject for the first time I'm hearing, and we are going to hear straight from Dr. Venkat Narayan what this disease is all about, why it is so prevalent, Indians and Indian immigrants, and what it has an implication in our way of life and developing coronary artery disease along with it. And he's also going to implement few things, particularly the COVID that is going on around, and his research and his topic today, what he's going to discuss will enlighten all these things. And here is our speaker, Dr. Venkat Narayan. In fact, he's graduate of St. John's Medical College in Bangalore. We, in fact, went both of us to St. Joseph's College in Bangalore. And he's a brilliant speaker. I'm very honored to present Dr. Venkat Narayan.
Thank you, Dr. Nayak. Thank you, Dr. Sudhakar. It's my pleasure. So what I will do is I will give my talk largely focused on the type 2 diabetes in Indians, talk about some of the unsolved mysteries, some of the potential phenotypical typical differences, and about what I thought, just to make things interesting, rather than present a lot of data on COVID, which you're all aware of. At the very end of my talk, I will conclude with a few important observations and findings that related to COVID we're finding, and then open it up to questions. So you can ask me a number of questions around it. So basically, like Dr. Nayak said, type 2 diabetes today is a pandemic. And this is where we talk of COVID as a pandemic, but really type 2 diabetes is also a very slow moving pandemic. The number of cases with type 2 diabetes is increasing in every part of the world, urban, rural, even in Africa, it's doubling within 20 years. And the Indian subcontinent happens to be one of the epicenters of this diabetes epidemic. Let's go back almost 50 years. In India, in 1972, the prevalence of diabetes in urban India was 2.3, and the prevalence in rural India was 1.5. It was a very rare disease in those days. A lot of us had went to medical school in India. We knew what diabetes was, but it was quite rare. At that time, the earliest observation about heightened risk of diabetes in Indians were made in immigrant Indians to several countries: Singapore, Malaysia, Fiji, Mauritius, South Africa, UK, Tanzania, where when Indians migrated to those countries, which in those days were richer in context, they developed much higher prevalence. So this idea that migrant Indians are at high risk of type 2 diabetes compared to native local Indians in India was a theory that has been held for the last 40, 45 years. There has been a lot of research as to why this might be true, and that is what I'm going to come to. One of the problems is when a disease is studied in a migrant population in another setting, some of the ideas from that other setting, dominant ideas, tend to overwhelm the literature, and this is where we need to be careful about. So this is going to be some of the themes of my talk. Very recently, about 5 or 6 years ago, one of my PhD students, we were talking one day and we said, this is Anjali, her name is Anjali Gujral. The idea was, the theory is migrants from India to other countries have higher diabetes than those who are living in India. Does this still apply? Or have things changed now in the last 40 or 50 years? So Anjali Gujral went about, there was a study called the CARS cohort in Chennai and Delhi. This is in Chennai. This is a representative sample of the population of Chennai. And there's a cohort called Masala, which is Indian Americans like us living in California and Chicago, run by my friend Alka Kanaya. So when she compared the prevalence, what she found was the Indians in urban India, Chennai, had a higher prevalence than Indian Americans in California and Chicago. True for men, true for women. And for comparison, that's the US general prevalence. So this is telling you two things. It's telling you, number one, on average, Indians overall are at higher risk of diabetes compared to the general population of the United States, which is majority white. And second, Indians in urban India today have a higher prevalence of type 2 diabetes than Indian immigrants in the United States. Again, flipping the idea that migrant Indians have a higher risk than those people in India alone. There are many reasons for it, and we are investigating it. So when you plot the studies in India, the prevalence of diabetes in India, starting from 1972, when I told you the prevalence was 2.3 in urban areas, 1.5 in rural, and then you can see right down to 2015. This was an NIH-funded study we did in Chennai and in Delhi, where the prevalence now is 24%. So a quarter of the population aged 20 and over in Delhi and Chennai are diabetic, and by age 50, that prevalence is almost 50%. So clearly a huge increase in the rate of diabetes in India within a span of 45 years. So the other observation that has been made is Indians have heightened diabetes risk, even at low body mass indices. And a nice, elegant study of this was again done by a PhD student of mine, Rina Oza-Frank, who's currently in Ohio. She took data representative of 34 million people in the United States. These are all immigrants born somewhere else, but who have migrated to the United States. And she looked at their diabetes prevalence according to their region of birth. So did they come from Europe? Did they come from Asia, etc.? And then she divided them into three groups: those who were obese, those who were overweight, those who were normal weight. And the first observation she made was people from the Indian subcontinent, India, Pakistan, Bangladesh, Sri Lanka, had the highest prevalence of diabetes among all immigrant groups in the United States, followed by African immigrants from Africa, not native-born African Americans, but African immigrants into this country. The second observation is very striking. This line is the prevalence of type 2 diabetes in obese European immigrants. So when you see that line, the Indians and African immigrants who are even normal weight have as high or even a higher prevalence of diabetes compared to your obese European Americans. This makes it a very striking issue. Why is this the case? So last year I was invited to give an award lecture. It was called the Gopalan Award. Dr. Gopalan was a hero of nutrition in India. He's now, he died at age 105. So this was a lecture in his honor. So they asked me to talk about diabetes. So I asked the question, why do South Asians have a high risk of diabetes at low BMI? And when I studied the literature, again, this has been the literature for the last 40 to 50 years, the dominant view in the literature are these three things. Even you might think this way, that South Asians are genetically predisposed, number one. They are more insulin resistant. They have higher visceral adiposity. This has become almost a kind of truth that everybody believes in. So as a scientist, one of the things that I like to do is ask whether these are really true. And I want to look at data, just like it was at one time true that migrant Indians had higher prevalence compared to Indians in India, but now that has turned around. Have things changed, or is this idea still valid? So firstly, in one slide, I want to summarize for you everything that we know about genetics of diabetes. I mean, this can be a 4-hour talk on its own, but I'm summarizing it to you in one slide. So far, there are about 400 odd SNPs, single nucleotide polymorphisms or genes, that explain about 18% of all cases of diabetes worldwide. So that's the first number one point. Secondly, diabetes tends to be polygenic, except for the rare variants of monogenic diabetes. And most of the SNPs associated with diabetes are not related to obesity or insulin resistance. Very important point. Thirdly, the common variants of genes for diabetes are similar across populations. I mean, this was a classic study done by Dr. Francis Collins at the NIH, who's the director of NIH. Basically, they found the common variants for diabetes are similar across all populations, including Indians. So there is no specific difference at a big picture level. Fourthly, adding all the genomic data to simple measures like body weight, age, family history, and a glucose does not seem to improve prediction of risk of diabetes so far. This might change in the future. And finally, for the last 30 years, I've been involved with lifestyle intervention studies, large classical studies. So lifestyle intervention, such as helping people lose weight, making their diet healthy, getting them to do more physical activity, seems to almost negate the excess risk, genetic risk from major genes. I mean, a famous quote from Jocelyn Diabetes Center: the genes may load the cannon, but it is always the environment that pulls the trigger. So what about epigenetics? So the fixed gene, there doesn't seem to be a difference. Might there be a difference in how genes express themselves? And here is a study which compared whites in the United Kingdom with Indian Brits, again in the United Kingdom, similar country, same population. They found 5 genes in this particular study that were associated with diabetes, 5 loci. But the methylation score on the 5 same genes, which were related to both populations, the methylation was higher in South Asians compared to the whites. This seems to suggest that although the fixed genes might be similar, something is happening in gene expression or methylation that is happening to the gene, either during intrauterine life or in early adult life, we don't know when, that might be of higher consequence in South Asians. So this idea that epigenetics might be more important in South Asians to explain diabetes rather than genetics is something that is beginning to gain attention. Now, I want to briefly take you back to some of the historic roots of diabetes in the subcontinent for 2 reasons. Number one, it's late in the evening, so I want to give you something interesting and exciting. And secondly, it also gives us context for where we might be coming from to understand diabetes today. These are phenomenal data, reconstructed heights of world population 10,000 years ago from various burials. So they took the skeletons and they reconstruct the height. Classic studies being done, largely led by University of Cambridge and other places. 6 different skeletal remains in 6 different populations in Western Europe, 10,000 years ago, which was the Mesolithic period. The Western Europeans men were about 160 centimeters tall. The women were about 150 centimeters tall. They studied 3 Eastern European populations around the same time period, from exhumed bodies. The men were about 170 centimeters tall, and the women were about 160 centimeters tall, pretty tall. They found 2 populations in South Asia. The Indus Valley civilization, which is which borders Pakistan, and which is in Pakistan and also in Rajasthan, India, and the Gangetic Valley civilization, which is in North India. And when they reconstructed the heights of those populations, this is what they found. At that time, 10,000 years ago, the people of the Indian subcontinent were the tallest. Men were about 180 centimeters tall. Women were about 170 centimeters tall. So why is height important? Height is, yes, part of height is genetically determined, but a large part of height is actually determined by maternal nutrition and nutrition during the first 3 years of life. So maternal child nutrition is a very powerful determinant of height and nutritional status of the offspring. But unfortunately, again, over the last 10,000 years, reconstructing the data, that black line that you see in the middle is the height of the people of the Indian subcontinent or South Asia. The heights have been going down, gradually over the last 10,000 years, suggesting that the average nutrition, maternal child nutrition and nutrition in general of the population has declined substantially during the last 10,000 years. Again, there are many reasons we can talk about this, but this is what data seems to suggest. And indeed, when you look at, these are studies of bone length in various populations. And when you look at different periods over the last 12,000 years, one thing is very clear. The average bone length in Indians has declined over about 11,000 years. So various studies that have been conducted by an anthropology group in Cambridge. Similarly, Indians have less bone length, which is a marker of lean mass compared to worldwide samples. So this is a worldwide sample. The ones below the line are the Indian samples over a period of time throughout history. For the last 11,000 years, we seem to have had lower and lower lean muscle mass. So when you understand from the skeleton studies, low lean muscle mass has characterized the South Asian population compared to worldwide samples. Stature adjusted lean mass has changed only minimally, and the stature decreased sharply when agriculture was adopted 8,000, 9,000 years ago, 7,000 years ago. And the lone lean muscle has characterized this population since the early Holocene, which is about 10,000 years, and may represent adaptation to climatic changes. That's where people are thinking at the moment. So this is a more recent study, actually comparing lean muscle mass in South Asians with Europeans using more state-of-the-art methods of measuring lean muscle mass. And what you see here in ages 10 to 18 years, these are young adolescent children. The South Asians have about 1 to 2 units lower lean muscle mass compared to Europeans, and this increases with time. So muscle mass deficit seems to be a characteristic of South Asians. This was a study done in France. They compared autopsy specimens of white French people with Indians in that country. And what they found was striking. The height adjusted organ masses from autopsies, the Indian organs were 10 to 35% smaller compared to the white French. They were smaller in BMI, smaller in weight, shorter in height, and their pancreases were smaller, their liver was smaller, their heart was smaller, their lungs were smaller. So in general, their organ sizes were smaller. Why is this the case? Would it also be because of poor nutrition over historical periods? So the evidence from the last 10,000 years gives us some context to understand why diabetes might be exploding in the subcontinent now. Firstly, the population of the Indian subcontinent has on average experienced a gradual decline in stature and in lean muscle mass. Secondly, has on average poor organ development, including liver, pancreas, lung, and also heart. The cause is speculative, but the adaptation to climatic changes and food availability may be some of the explanations. So coming to the very important point here, type 2 diabetes is really an ancient disease, which is today meeting a global 21st century lifestyle. That's what's going on. So when you go into the history textbooks of diabetes, you can study Romans, Greeks, Arabs, Indians, and diabetes has been described. For the last 2,000 years, people have described diabetes in all kinds of forms. And I actually found a very interesting quote in Charaka Samhita which is an Ayurvedic Indian textbook written in the 6th century AD, they say there are two forms of diabetes. They call it madhumeha, which is honey urine, one associated with emaciation, dehydration, polyuria, and lassitude, and the other with stout built, gluttony, obesity, and sleepiness. Very remarkable in terms of it almost sounds like type 1 and type 2 without modern technology described 1400 years ago just through observation. So now I want to briefly, in about 3 or 4 slides, touch on the economic history of India, because I think this would give us further clues to what may have happened. Firstly, this is a phenomenal classic study done by Angus Addison, a developmental economist, who studied the economy of world history over the last 2000 years. So what he concluded was for the 80% of the last 2000 years, until mid-1800s, the two largest economies of the world were China in red and India. So different times, one were higher, the other time other was higher. And then you start seeing the rise of Western Europe and the rise of UK. And then only in the early 1900s, you start seeing the rise of the United Kingdom. And then towards the early part of 2000, you're beginning to see the expansion of China. Now some expansion of India is also going on. This does not mean money is moving from the rich countries to the poor countries. This is about production, a country's overall production. But to understand this phenomenon better, I focused down on this 250-year period from 1700 to 1950, when India was under the British influence in one form or another. So during this period, when you look at GDP per capita, inflation adjusted, the per capita GDP of India stayed constant, whereas the per capita of GDP of Britain in a 100-year period rose by about 7 times using today's dollars, 7-time increase. So we've all gone to medical school in India and we were taught that India was poor because of the large population. So I said, let me look at the population. And interestingly, in 1700, for every 100 people in India, there were 5.2 people in the United Kingdom. But in 1950, for every 100 people in India, there were 14 people in the United Kingdom. So not only did UK's per capita GDP increase 7 times, UK's population increased 3 times faster than the Indian population. So their overall GDP was 21, 22 times higher. They were able to distribute it among the population. So population was not the reason why India remained poor. That's an important point here. Since independence, you can see the GDP of India from 1950 remaining flat till the early 80s and then beginning to go up. And why is this important? When you start mapping that with the diabetes prevalence, it tells you an important story. In the last 40, 50 years, you're seeing this dramatic increase in diabetes prevalence. This happens to be in the city of Chennai, where they have done careful studies. But this is true in many parts of India. You can study any Indian city or even any Pakistani city. We also study Karachi, for example. The picture is not that dissimilar. So something about modernization happening in the context of a population that has had historical undernutrition is something that is beginning to happen. So today, when you compare Asian Indians in Chennai here with whites in the United States from the enhanced study, you find that the Asian Indians have higher prevalence of diabetes than every BMI group. But what is striking is even your underweight and normal weight Indian groups have very much higher prevalence compared to white normal weight and underweight people. In fact, in Chennai, the people who are underweight and normal weight have a prevalence of type 2 diabetes of 7, 10% even. So why are thin people developing type 2 diabetes? Okay, the obese people developing type 2 diabetes, the causes might be very similar to what is happening in Europe and the Western countries. But when thin people are developing type 2 diabetes, you need to ask the question, why? And this is where, let's now switch. I worked with the Pima Indians of Arizona, an NIH study, which has been going on since 1960. The Pima Indians are a pre-Columbian migration to the Americas. They are thought to have arrived to the Americas 35,000 years ago. They probably originated from Central Asia, based on DNA evidence. They wandered into the Americas during winter when the Bering Land Bridge would freeze, but in summer the bridge would melt. They wouldn't be able to go back. So they were hunter-gatherers. They would wander into the Americas. A large number of them went to South America. Some of them settled in Mexico. And a small number of them came back to Arizona and settled in the Gila River, the banks of the Gila River. And for thousands of years, they had a civilization that was based on agriculture. And all the studies at that time showed they were a thin, fairly fit, population. They were dying young. That was a different matter because of TB and other things. But suddenly, in the early 1960s, an NIH study demonstrated an explosion of diabetes in that population. Till 1930, there was not a lot of diabetes in that population. But by 1964, when they actually went in to study rheumatoid arthritis in the population, they were doing glycosuria. They found 50% of the patients had glycosuria, and 50% of the population, when they did a glucose tolerance test, had type 2 diabetes. All of it was obesity related. All of it was type 2 diabetes. 50% of the population by age 45 had diabetes. Obesity was the driving factor, and this was due to rapid changes in environment and lifestyle. So the theory that they put forward at that time, based on the Pima study, was a population is genetically susceptible, develops obesity and then becomes physically inactive, and with aging, insulin resistance or poor insulin action develops, and then the body pumps out insulin to maintain glucose control and develops impaired glucose tolerance or prediabetes. And then finally, the body is unable to meet the demand of insulin, and the beta cell starts declining, the function starts declining, and type 2 diabetes develops. So this model, this paradigm, has dominated the literature for the last 40 years. We said, okay, we are finding high prevalence of diabetes in India. We have studied the Pima Indians here. Let's compare this. So we undertook a comparison of the two populations, and my colleague Lisa Steinmetz, as part of her PhD, did this analysis. So when we compared, what we found, these are Asian Indians in Chennai, India. These are the Pima Indians I just told you about, a population with the world's highest diabetes prevalence. By age 55, both the populations, 50% or half the population, were diabetic in both populations. But when you looked at the obesity levels, the Pima BMI was 33.7, their waist circumference was 108.6, but the Asian Indians in Chennai, their BMI was 25.7, and their waist circumference was 83. So the Pimas were 7 BMI units heavier and 25 centimeters larger in the waist, but still both populations have similar BMI, similar diabetes. The glucose profile was very different. The highest, the glucose pattern in Pima Indians was high 2-hour glucose after a glucose tolerance test, whereas in Asian Indians, it was a high fasting glucose. Then when we measured insulin secretion and insulin action, the Pimas were 2 to 4 times more insulin resistant than Asian Indians, even at normal BMI, even at normal glucose levels, whereas the Asian Indians were secreting half to a third of the insulin compared to the Pimas, even at low BMI, even at low glucose levels. And indeed, going back to what I just told you a while ago, when you map the genes, all the 400 odd genes that we know for diabetes, those genes for diabetes and glucose don't seem to overlap much with the genes for BMI or obesity or waist circumference, etc. There is some overlap, but not a lot. This suggests that the factors driving type 2 diabetes are due to genes related to insulin secretion or beta cell function, or it might be epigenetics of those genes. And indeed, in the last 10 years, we've conducted a number of very detailed studies. Indians in Chennai, Indians, young type 2 diabetes in Chennai, Indians in Chicago, in California, etc., and consistently finding data suggesting that the Indian population may be secreting less insulin to start with, because when you're secreting less insulin to start with, you don't have the ability to compensate when you start going on to a high carbohydrate diet, refined carbohydrate diet, or of low physical activity or small amounts of obesity. This is what Lisa showed. Basically, when you look at people, this is 1,200 people with NGT, normal glucose tolerance, impaired glucose tolerance, both IFG, IGT, and diabetes. The insulin secretion, or what we call beta cell function, has declined very early. So the idea that insulin secretion decreases later is not true. It decreases very early in the natural history. Even before somebody develops diabetes, there's evidence of declining insulin secretion. And Alka Kanaya from University of San Francisco, she compared South Asians in black with Chinese Americans, with Hispanics, African Americans, and whites. She measured insulin secretion, and the South Asians, these are non-diabetic people at all age groups, have poor insulin secretion. So even non-diabetic South Asians have poorer insulin secretion compared to other populations. The Chinese are also low, but not as low as South Asians. But the other three populations don't seem to be low. What separates these two populations is Chinese and South Asians come from countries that have had malnutrition for generations, and particularly for the last 100, 200 years, whereas the whites, the Latinos, particularly in many Mexicans, etc., have had good nutrition for at least for the last 50 to 100 years. So this is a classic study called the New Delhi Birth Cohort Study. They studied children from birth, they measured their height, weight, glucose, etc., and they monitored these children through adulthood. So this paper was published in the New England Journal of Medicine some 10, 15 years ago. What they found, they mapped the glucose trajectory of the children from birth. The green line is the glucose trajectory of children over age who were born of good weight at birth. These were children who were well nourished at birth. And the red line are children that were stunted or undernourished at birth. And what they find was that the children who were undernourished or stunted at birth, they developed glucose intolerance, diabetes, pre-diabetes much faster than the others who were healthy. Again, indicating something early in life, maybe maternal nutrition, maybe poor nutrition in childhood, sets the timeline for developing glucose intolerance. At that time, based on the world literature, the conclusion made by the authors was that those who went on to develop diabetes, they became obese relative to themselves. They were saying they had greater visceral adiposity. They were putting fat in the wrong places. That's why they were becoming diabetic. But I think we have an alternative hypothesis, which might be a complementary hypothesis. Both of them might be true. But our data is beginning to suggest that those who went on to develop diabetes may have poor beta cell function to start with. So the problem may not just be fat deposition. It may have to do with poor insulin secretion to start with. So, and that's also true in the Harvard cohort studies, where low birth weight is a strong risk factor for type 2 diabetes. In that study, 22% of diabetes was attributed to low birth weight alone, 59% to unhealthy adult lifestyles, and 18% to the interaction. But this was a population that was already well nourished. If you did this study in India, you will find the contribution of low birth weight to be much higher. And then in Vellore in India, a colleague of mine in Einstein in New York and a colleague in India have been doing these wonderful studies of low birth weight infants and looking at their metabolic control. So they did very careful, state-of-the-art measurements. And what they found was this. Children who are low birth weight, these are male children, compared to normal weight children by age 19, were shorter, were lighter, had lower muscle mass, had a trend towards lower mineral composition. They had higher blood pressure. They happened to consume lower dietary protein. That might be because they were poor, we don't know. They did not show any difference in insulin sensitivity at age 20. So insulin resistance was not the problem. And then they went on. This is what they studied. When they studied, they found that the people developing type 2 diabetes, or the lean ones developing type 2 diabetes, were in fact secreting less insulin. These were carefully done clamp studies showing poorer insulin secretion in those who developed diabetes, either type 2 or type 1, or those who were lean. That's the purple line. They had very poor insulin secretion at very early ages. We did a trial in Chennai. This was a diabetes prevention trial. We recruited 550 pre-diabetic people in 3 groups, IGT, IFG alone, or both. And we gave them 4 months of lifestyle intervention, 24 sessions, got them to lose weight. And then if they did not still have high glucose levels, we added metformin. So we were targeting insulin resistance. And then we found overall there was a 32% reduction over 3 years in the risk of developing diabetes. But that benefit was only present in the IGT group, which is a group that is insulin resistant. It was not so strong in the IFG group, and IFG is a combination of hepatic insulin resistance and poor insulin secretion, whereas IGT is peripheral insulin resistance. And indeed, when you look at the Indian population, the majority of people with prediabetes, this is what you will find in your populations too, happen to have IFG, not IGT. So lifestyle intervention has some benefit, but not as strong as the IFG group, and in fact, not as strong as in Western populations. When we did this study in whites, the reduction in diabetes incidence was 58%. So the diabetes lifestyle intervention has a weaker effect and much weaker in the IFG group. Indeed, this was a study done by Salim Yusuf in McMaster's. This was rosiglitazone in different populations. And look at this, when you compare the different regions of the world where he did the trial, the Indian population had the smallest effect from rosiglitazone on preventing diabetes. So targeting insulin sensitivity, targeting insulin resistance seems to have a weaker effect in Indians compared to other populations. And more recently, there are studies showing that the DPP-4 inhibitor might have a stronger effect in Indian populations compared to other populations, because that might target insulin secretion and beta cell function. So, I mean, this is a beautiful meta-analysis of birth weight and type 2 diabetes. They did what's called a Mendelian randomization. And basically they found in a very large study of 41,000 cases of diabetes, 80,000 controls in 49 studies, one standard deviation decline in birth weight at birth was associated with 2 times the odds of developing diabetes by adulthood. But this association was only for fasting glucose. They didn't find the association for 2-hour glucose, suggesting that this low birth weight probably impairs insulin secretion, impairs pancreas, impairs the liver, and sets into motion diabetes in thin people, which is what we are finding. And the causal association was stronger at lower BMI. My colleague Anjali Gujral published this in the Annals of Internal Medicine, looking at several populations, ethnic populations in the United States. I mean, look at this. These are normal weight people. 52% of normal weight South Asians have some metabolic abnormality, low HDL, high triglyceride, high glucose. That kind of abnormality is also present in whites, but a much lower proportion, is about 17%. So these phenotypes are present in all populations. It's not specific to Indians, but the Indians have more of it. That's the point here. So the other question is it visceral fat or can it be something else? So here, these are unpublished data from a very good meta-analysis done by a colleague in England. She compared South Asians with white Europeans. She did a meta-analysis of all the studies that have been published. South Asians in general were 2.5 times at risk of developing diabetes compared to white Europeans. They had 1 BMI unit lower, but there was no difference in visceral fat between South Asians and whites, both in men and women. So the idea that South Asians have higher visceral fat is challenged by these analyses. What she found was, yes, South Asians had more fat, but most of that fat was subcutaneous, which tends to be harmless, but the harmful fat was fat in the liver. South Asians had greater liver fat. So this idea that South Asians have more visceral fat needs to be understood more granularly. What they have is more subcutaneous fat, which may not be harmful, but they have more hepatic fat, which might be harmful. And again, This is a study in Vellore, which we were involved in. So if you look at diabetes, the people with diabetes have higher hepatocellular lipid deposition, whether it's type 2 diabetes, lean diabetes, type 2 diabetes, etc., and even pancreatic lipid deposition. So hepatic and pancreatic lipid deposition is very high in those with diabetes. And a PhD student of mine, she just finished it. This is not in South Asians, but she tried to look at metabolomic markers of hepatic problems. And she really found 3 different clusters of metabolites. And one of the clusters, which is strongly related to cardiometabolic disease, was available. And this was related to certain protein metabolism. So there might be something to do with protein, fat deposition, or fat intake, carbohydrate intake on the liver, and that might be very important to think of. So let's get back to my primary question, and I will finish my talk in the next 10 minutes. Why do South Asians have a high risk of diabetes? I think, from the data I've shown you, that the evidence suggests that they are more insulin deficient than insulin resistant. They display a propensity for high ectopic fat than overall visceral fat. They respond less to intervention that alter insulin sensitivity and insulin resistance. So let's go back to what the literature said. Like I told you, the dominant view in the literature versus the evidence that I've provided you. The dominant view is South Asians are genetically predisposed. But the data suggests no, there is no difference in fixed genes. The real difference might be in epigenetics. Important message. The dominant literature suggests that South Asians are insulin resistant. You can read it everywhere. Everybody writes about it. I think no, they're actually more insulin deficient. They're not insulin resistant. And we have 2 papers under review in BMJ at the moment. The literature suggests that we have higher visceral adiposity, but the data seems to suggest the real problem is hepatic fat deposition. So this is why I think it's important to be critical of what is published. So based on this, we published this hypothesis paper earlier this year. Our hypothesis is the South Asian population is at heightened risk because of these 2 factors. Number 1, evolutionarily determined, they have poor beta cell function and low lean muscle mass, and this impairs insulin secretion. And in the context of this poor secretion, the response to lifestyle, they deposit fat in the liver. Might be because of high carbohydrate intake, might be a poor, low protein intake, whatever the reason is, and that impairs insulin secretion. So this combination is very toxic, and therefore they rapidly develop diabetes, even when they are thin or even very faster than other people. So it's time to consider heterogeneity of diabetes. It's not one disease, it might be multiple diseases, it's type 2 diabetes. And some years ago, for the Kelly Ward National Scientific Award lecture for the American Diabetes Association, I presented the concept that maybe it's time to start thinking of type 2 diabetes at least as 2 groups. 2A, which is because of high metabolic load. The primary problem is poor insulin action. The causes might be adiposity, physical inactivity, dietary factors. The diagnosis might be a high 2R glucose. The initial treatment might be usual, lifestyle and metformin. The classic ethnic group might be the Pima Indians. Whereas there might be another type, the type 2B, which I call because of poor metabolic capacity. The primary problem there might be insulin secretion. The causes we don't know. It's very speculative. It might be poor maternal nutrition, early childhood nutrition, reduced beta cell mass. It might be microbiomes. It might be lipotoxicity. It might be endocrine disruptors like toxic pollutants. It's a possibility. And the diagnosis might be a fasting glucose and a 30-minute glucose. Early 30-minute glucose seems to play a role. The treatment might be lifestyle intervention, might have some effect, but we may have to use secretagogues, gliptins, early leptin, insulins, etc. The classic ethnic group might be Asian Indians, and all other groups might be in between. And look here, I'm not suggesting that only one of the pathophysiology is related to one of them. I think in both conditions, you have both pathophysiology. The question is which is dominant, which comes first, insulin secretion or insulin resistance. So this was another study we did in Chennai in collaboration with a group in Denmark. We looked at 5,000 people, measured their 2-hour glucose at fasting, 30-minute glucose and 120-minute glucose. And we found 4 different glucose patterns. If we did CGM, we might find more patterns. But essentially, there was one group that was normal at all 3. There were 2 groups that had high fasting and high 2-hour glucose. But look at that group in purple. They had normal fasting glucose, normal 2-hour glucose, but they had a high 30-minute glucose. And this group, which we normally miss, was about 25%, 22 to 25% of the population of Chennai. And that group is also at very high risk of developing diabetes within 3 years. So they may have a normal fasting glucose, they may have a normal 2-hour glucose, but if you measured a 30-minute glucose and that is high, they are also at risk of developing diabetes. And these are likely to be your thin people developing diabetes who may be insulin deficient to start with. They're not type 1s because they don't have antibodies. So lo and behold, a couple of years after we published those data, a group from Sweden and Finland came up with this brilliant analysis published in the Lancet, showing using 6 variables. They came up with several phenotypes of diabetes. They came up with 5 different phenotypes of diabetes. 2 of the variants, one was type 1, the second was clearly type 2, but was related to insulin deficiency and it was early onset, and there was also relatively low BMI. And there were 3 other groups, one that was related to older people, one that was related to obesity, and one that was related to high insulin resistance. So again, 2 groups that are insulin deficient, 3 groups that are insulin resistant or poor insulin action. This was basically, that's what it shows. And then this study recently has been replicated in Chennai by my colleague, Dr. Mohan. So he found something quite similar. He didn't look at type 1, but among type 2, he found the similar 4 groups that they found in Finland, where there was one group that was early onset diabetes, low BMI, had poor insulin secretion. They had low C-peptides, whereas there was one group that was a high BMI. There was a group that was related to aging. And so this suggests that there might be different types of diabetes, their diagnosis might be different, their treatment might be different, their prognosis might be different. And indeed, that is why it is important to know this. I mean, as you see here, there are some groups that are more likely to develop retinopathy. There are some groups that are more likely to develop nephropathy. There are some groups that go on to develop chronic kidney disease, etc. And even when you look at their glucose trajectory over time, some groups are easier to control their glucose, some groups are not easy to control. And so this is why we need to maybe understand the phenotypes better, become more precise in how we are dealing with them and controlling them. So at least in Chennai, with these simple 6 variables, age at diagnosis, BMI, waist circumference, A1C, a triglyceride, and HDL, they were able to come up with 4 groups. And these 4 groups might be important. I think this whole area needs to be studied better. So to summarize, people of Indian descent, and these are people from India, Pakistan, Bangladesh, Sri Lanka, Mauritius, Bhutan, Nepal, etc. They are at high risk of diabetes, even at low BMI. And a dominant factor seems to be insulin secretory defect, low lean muscle mass, and a propensity for hepatic fat deposition. We need to consider the heterogeneity and phenotypes of type 2 diabetes. Maybe this is something we need to start thinking about. Should they be diagnosed differently? And this is an area we're beginning to research. Should the treatment be different? The order of treatment be different? Should we, what's the best way to treat different groups? Are their prognosis different? Are the type of complications they develop, is it different, etc.? And there is a huge research gap in diabetes. And this is quite shocking. 90% of diabetes worldwide is in low and middle income countries like India. But 97% of research in diabetes comes from high income countries like Europe, United States, Canada, Australia, etc. This is a problem. So all of this information sometimes is misguiding. And this is why I think we need serious international effort We need investment and research in Indian Americans here in the US and in Indians in India. And we need support for this. And, places like NIH fund this. But, I think what we have studied from places like Japan and other studies is that, involving the diaspora in supporting this is extremely important. And I promised you, I'll tell you something about some of what we are learning from COVID. We're learning a number of important things from COVID, which connects with a lot of these things. There seems to be an increased risk of diabetes in people developing COVID. In fact, even those without diabetes present with hyperglycemia, and people with diabetes, a high proportion of them present with diabetic ketoacidosis. And early studies seem to suggest that the COVID virus also seems to attach itself to the ACE receptors in the alpha and the beta cells of the pancreas, suggesting something in the beta cell might be important to think of. Secondly, somebody asked me, we all know that people with diabetes seem to be at high risk of COVID complications. You look at the patients getting admitted to hospital, the patients going to ICU, the people dying. There's a higher proportion of people with diabetes where it happens. There might be 2 or 3 reasons for it. One might be that the socioeconomic factors related to diabetes, poor people, lack of access, etc., might be similar to the socioeconomic factors related to COVID, especially in countries like India and also in the UK, that's what they're finding. And secondly, the pathophysiology, things like inflammation seem to be common both in diabetes and COVID. So people with diabetes already have impaired immune function. Exactly how, where, is it beta cell, is it B cells, T cells, what's going on? And then, maybe they're more vulnerable, they develop inflammation more rapidly. So let me stop there and give you time for questions and answers.
This is Dr. Naik again. I'm a moderator. Really, it is a very, very interesting topic that you discussed, and particularly the way you brought up in Indians, we are high risk. And we were thinking all the time, and visceral adiposity is one of the biggest factors in Indians, but now you are telling fatty liver-like situation. And previously we used to think the Indian producers, they produce more insulin, but they're insulin resistant. But now you're telling that insulin is deficient in these patients. It is a very interesting study. For the past 45 years, I've been in academics and I've been trying to learn few things. But your talk was very scientific and very powerful message that you are giving to us and all the Indian physicians, those who are on the line right now. And your discussion was very, very useful to all of us. And there are certain questions that are coming to my point of view is this. I was reading about the in diabetic research, gastrointestinal tract, bacteria, virus, and all the toxins, they are attributing some of these factors to produce the diabetes. And we Indians who consume so much of carbohydrate and diet, is there anything that will be related to development of diabetes in Indians?
Yeah, firstly, I want to say something very clearly. Having said all this, the role of exercise, regular exercise, 30 minutes to 1 hour of walking at least a day, or whatever you want to do, plus a healthy diet. A diet that is not high in refined carbohydrates. I think high fiber diet, things like brown rice, diet high in fruits and vegetables, less of fried food, less of sugary food. I think all of that, and high in nutrients, the general micronutrients. I think those kind of things, and high in somewhat, greater consumption of small amount of nuts, more of monosaturated fat like olive oil. All of that is definitely important. I think the Indian population doesn't have all that, and the reason that is important is when you start off with two disadvantages. Number one, you have a problem of secreting less insulin compared to others. So your reserve is low. And secondly, your whatever fat you do, a lot of it goes directly to the liver and causes hepatic insulin resistance. So when you are at that risk, the longer you are able to maintain yourself, in a fairly thin way, healthy way, your body's insulin is able to compensate. So it's important to do that. Secondly, in terms of your question, the question is there anything in the gut? Was that your question?
Yes.
That's an interesting question. People have not, the question is, are there differences in the microbiomes? It's early stages of research. There are some microbiomes that seem to be related to obesity, some that seem to upset glucose metabolism, but that's a very early stage, amount of studies going on. That needs to be studied better. Some people will say that might be important. I think this is something we need to study, because when you think of a population that moves from India, migration from India to here, the diet changes, the environment changes, the microbiome environment changes rapidly. So some microbiomes is common to us. Dr. Nayak, you may have some microbiome which is specific to you, but some that you acquire from your environment, some may be harmful, some may be good. So this is where these are the studies we need to conduct. And in fact, at NYU, there are people studying the role of microbiomes and fecal transplants, etc. But that's still very early stages.
There is a question now from one of the doctors. He's asking if it is a hepatic, so-called fatty liver, whatever you are describing in this, do we have any remedy for this, or just we are talking about something semantic, saying that it is there, probably it is a part of the disease process?
I think it's both. I think the answer is both. Clearly, there's a lot that can be done to prevent hepatic fat deposition. I think clearly all of the good lifestyle factors that I mentioned are good to prevent hepatic, fat deposition. So that's important. And secondly, studies have shown that even people developing hepatic fat, when they go on to the kind of diet, the diet which is lower in refined carbohydrate, a diet that is slightly higher in protein. Protein, deficiency seems to be quite common in our foods too. And diets that are richer in fruits and vegetables, physical activity, seem to reduce hepatic fat deposition. It's not a hopeless case. There are remedies, and also people are studying drugs like metformin, etc., in what they do, and there are some early signs that might be useful. But I think prevention is important. Alcohol intake also, for example, small amounts of alcohol might be okay, but alcohol intake in excess clearly, promotes hepatic fat deposition. So I think, if there is one important thing we can do now while research is happening, we can definitely take care of our lifestyle. And I think it's important that we can do it. Can we increase our protein intake? Can we improve our muscle training so that our lean muscle goes up?
Yes.
Can we reduce the refined carbohydrate so that carbohydrate load goes down? Can we increase our fruits and vegetables, our fiber, so that we keep our livers protected? I think that's and then sleep is another very important. A lot of research coming into the area of sleep. 7 to 8 hours of high quality sleep seems to improve insulin action. So I think those things are important. And there are also studies showing that aerobic, high intensity aerobic activity may improve insulin secretion. So there are some of these things. So there are things that you can do, but there are things that we don't know. And that whole area that we don't know is how do you improve insulin secretion? I think that's an important area. And I think what we need different trials. In thin people presenting with type 2 diabetes, is the order of therapy right? Should we start with metformin, or should we start with the DPP-4, or should we put them on Dr. Mohan in Chennai would say, start with insulin for a first several weeks first, get rid of the glucose toxicity, and then control becomes easier. So there are all of these ideas. We need to do better studies and get better protocols for the order of treatment. I think that's going to be important.
There is one Dr. Dev is asking a question.
Yep.
He's asking, intermittent fasting, is it a good idea to prevent diabetes?
There have been studies done of severe fasting. I mean, there was a study done in England where they put people on close to liquid diet, 800 calories for 4 months. And then at the end of it, they reduced it and they were able to show reversal of diabetes. But the problem with those diets is that is it sustainable and what other harm does it cause? That those people have not followed up. The intermittent diet, a lot of ideas have come up about it, but the latest evidence based on the systematic reviews seem to suggest that they may cause more harm than good at the moment. We don't know because what happens is, think about it like this: when you're on fast, your body. The thing about evolutionarily, the human body is very sensitive to fasting, extremely sensitive to fasting, because we've
Yes.
come through starvation in the past. So the moment the body senses fasting, the ghrelin and the leptin hormones and everything starts getting altered. The body is kicking back. The body says, "Come on, save, low down," and it lowers the metabolic rate. So your body is trying to protect itself. And then when you eat, you might think you're eating the right amount, but the body's metabolic rates have gone down. So you tend to store it as fat. So studies show that over a long period of time, intermittent fasting could actually cause more harm because it worsens the underlying metabolic thermostat. So I think it's better to be on a steady program rather than this dramatic program. It's better to accept. Some studies show if a person is very obese, there might be a role in bringing down the obesity fast for a while and then maintaining it. Like, for example, studies of bariatric surgery show that immediately after bariatric surgery,
Yes.
diabetes reverses, but that may have to do with the gut hormones. It might have to do with the GLP hormones rather than anything else. So these are all very interesting questions, and we need a lot more research. But intermittent fasting is not something that I personally have much faith in, based on the data I've seen.
Avinash Gupta, he's asking, I think you already enumerated this, why COVID is so severe in diabetic.
Yeah.
You mentioned already, but can you enlighten?
Yeah, I think two reasons. Number one possibility is the socioeconomic factors. The people who develop COVID and the people who develop diabetes may have some similarities, at least definitely in countries like India. They both seem to be people from poorer neighborhoods, etc., crowded areas, poor access to exercise, etc. So that might be one factor which is important to take into account. But biologically, it may have to do with both diseases. Somebody with diabetes have high inflammation anyway, and their immune function, that might be because of their immune receptors. They may be, or their response might be impaired. Like people with diabetes, their response to vaccine might be impaired too. So when they develop COVID, maybe the same mechanisms are fighting against them. And the third idea that's been put forward is maybe in people with diabetes, the ACE receptors might be a little more sensitive, and the COVID goes and attaches itself to it. So there are all of these ideas and theories going on, and the question that comes up is, should people on diabetes remain on ACE2 inhibitors and AR inhibitors? But the studies so far show that there's no reason to stop them. They should continue on those.
There are a lot of questions have come up, and one of them is everybody's asking what causes the increased hepatic fat in Indians, and how does this has the higher in gluconeogenesis leading on to the higher fat, diabetes.
I mean, several possibilities. I mean, one, like I said earlier, some of the studies showing we do have smaller livers. Maybe we have smaller hepatocytes. That's one possibility. And therefore, our diets tend to be higher in refined carbohydrates. All of those things may be playing a role in this. So, and then maybe we're not physically active. All of those roles might be playing a role in it. The person studying, hepatic, fatty liver is somebody called Paul Thulworth at Johns Hopkins University. And the other possibility is whether there is exposure to viruses in India, hepatitis viruses, etc. There are all kinds of interesting theories about this. But what we are observing is if you took a random sample of 10,000 people in Indians and you measured their hepatic fat with MRIs, etc., you find a high proportion of them with fatty liver and a small proportion of them with, yeah, that's something that you find. So
the one more question has come from Anuvedya. Is GLP-1 receptor agonist in the management of type 2 diabetes, are they intended for a chronic use, or when should we consider stopping it?
Again, this is again, these are the kind of questions which require proper data. These are really the kind of questions that require proper data. And again, might also goes back to the phenotypes. It depends on the phenotype that you're talking about. And maybe in some groups, earlier use of GLP-1 receptor agonists might be a better idea. But I think these are the trials we need. And I think this is why getting places like India involved in trials is very important. I think this is where a lack of research in the Indian subcontinent has been a problem. When I look back to my medical school days, the analogy that comes to my mind, which might come to all of your mind, think of amoebic liver abscess. We were all taught in medical school, it's the pus of anchovy sauce. Pus looks like anchovy sauce. None of us had seen anchovy sauce in our lives, but we memorized something which was written in a British textbook without thinking about it. So the contextual information comes from another population. I think this is why it's important to do studies in the same populations. We'll find very interesting things. I think, ever since the last 10 years that I've been working with Dr. Mohan and Dr. Nikhil Tandon at the All Indian Institute of Medical Sciences, they say half their patients don't respond well to metformin. They respond to a sulfonylurea. And the same idea in Karachi. So why is that different? So we need to do better studies in these populations, including like GLP-1 receptor, how long do you use it, etc.
I was involved actually in the study where we wanted to use rosiglitazone for the prevention of diabetes in India and reduce the coronary artery disease.
Yes.
That was totally a flop. We really.
I mean, so that drug was also discontinued. And in the DPP trial, which is a 27-center trial, we tested 4 things: a placebo, which is lifestyle advice, a group that received metformin, a group that received troglitazone, and the 4th group that received intensive lifestyle, that is 24-week session of getting people to lose weight. The group on troglitazone, we had to stop the trial at 14 weeks because of liver adverse effects. And the group with metformin, the benefit on diabetes prevention was about 30%, 29%. The group that received lifestyle intervention, that is, we got them to lose 7% of the body fat. We got them to exercise for 45 minutes a day. And that group, the reduction in diabetes incidence was 60%. So, and that was true across the board. So there is a lot a lot we can do now from lifestyle intervention to prevent diabetes. That's something that's been very important.
Well, your talk was very, very interesting, at the same time very educational, and you're doing so much of research. I just wanted to know, for all our group, what is the message that you are delivering right now?
Okay, the first message I want to deliver is there can be lots that can be done to prevent or at least postpone diabetes. And the diabetes risk is very high. There's a paper coming out soon. The diabetes risk in India is extremely high. Okay, but there's a lot that can be done to prevent based on the knowledge we have, and that prevention goes back to very simple things like good lifestyle. So in terms of diet, try to avoid excessive amount of intake. Keep your intake adequate. Number one, reduce the amount of refined carbohydrates, particularly white rice, sugary diets, etc. Reduce the saturated fat, particularly fried foods. Reduce that. Increase the amount of fiber, like brown bread, wheat, brown rice, etc. Increase the amount of fresh fruits and vegetables in the diet, extremely important. Increase the amount of nuts in diet. Small amounts of nuts like cashew nuts, small amounts are good for you. Monosaturated fat is a lot better than saturated fats, so olive oils, etc. are very good, are good for you in small quantity as long as you don't fry them. physical activity, extremely important. I mean, essentially 45 minutes to 1 hour of walking a day, we can do a lot. Sleep, regular sleep pattern, 7 to 8 hours of uninterrupted sleep is important. And the last thing, which is very important for Indian populations, is avoiding meals very late at night. You want to have your last meal at least 2 to 2.5 hours before you go to bed. You don't want to go to bed on a full stomach. I mean, I tend to have my dinner by 5:30, 6 o'clock. That's been my habit. So I think some of these things are what what are worth doing. And that's number one message. My second message is look out for how different people presenting with diabetes might respond, whether the thin people also respond differently. And I think in this area, we probably need more research about what's the order of therapy, how do we diagnose? Like, for example, if you did a 3-step glucose tolerance test, 0, 30-minute, and 120-minute, I bet you will find a large number of Indians who have normal fasting glucose, normal 2-hour glucose, but high 30-minute glucose. And if you followed them up for 3 years, a lot of them will go on to develop diabetes. So that group might benefit from early lifestyle intervention, might even benefit from other treatments earlier on. And then whether we should treat people with diabetes initially early with insulin for a while, and then put them on oral hypoglycemics, and what is the right order of oral hypoglycemics? These are research questions. Again, people like Dr. Mohan and Dr. Nikhil Tandon in Delhi are doing a lot more research in this area. So that would be important. My third message, as Indian Americans, we are a lot of great physicians here. We are a very wealthy community. I think we should support research in Indian Americans and in Indians in India. When you look at how research has grown in other populations, it has happened because of support from the population itself. So this is, as a physician here, as a member of RP, this is something that I want to appeal to all of you.
Now you are in Emory, you are taking this project and doing research, particularly South Asians and Indians. Happy as a group, do you want us to get involved more in funding for the research in this endeavor, what you are trying to do?
Yeah, absolutely. I mean, most of our funding has come from NIH. Some
Yes.
of our funding has come from foundations and some, private individuals. Getting studies funded in India, or even in Indian Americans here, is very difficult. It's challenging, but we have done it. For the last 15 years, we've got funding from all kinds of different sources. But I think what would help us is clearly API as an advocacy group can lobby for more funding for through the government for studies in India, Indian Americans, etc. And any, just like we get foundation grants, my chair is funded by the Hubert Foundation, and so the Woodruff Foundation funds me. So the Jewish American Society funds me. So there are ways in which, if there are ways in which you can help us, we would, appreciate it at most. And what it does, we are improving the scientific knowledge here and in India, and we have trained 200 odd PhDs and postdoctoral fellows in India. So the base is getting improved in India. And yes, clinical care is important, but building strong science will improve clinical care dramatically, I think. So there are all kinds of ways in which you can support, whether it's fellowships, whether it's funding research, anything. We would definitely appreciate it.
Well, on behalf of the AAPI, and I think Sudhakar is on the line, your talk was very interesting and very thought-provoking, at the same time beneficial to all our physicians, and we deeply appreciate your presentation. It was fantastic. It was scientifically based, and you have done a wonderful research, and keep doing and bring the better message for us so we can have a good outcome in long run. The diabetes prevention and treatment in Indians is as important as any part of the world, because we see a lot of coronary artery disease in Indians in this country, tremendous amount of coronary artery disease, and that is pre-existing with the diabetes.
Yes.
So therefore, it is really a very good message. And on behalf of the organization, I thank you very much for your wonderful presentation.
Thank you.
Thank you.
Thank you, Dr. Nayak.
Yeah.
Thank you.
Mm-hmm.
Dr. Sudhakar Janalgada just stepped out because he had another engagement. I'm Dr. Ravi Kohli, Vice President of API.
Yes.
A two force of a presentation covering anthropology, economics, genetics, epigenetics, and epidemiology and investigation and intervention. It's a really a spellbinding presentation. And we have Dr. Sajni Shah, the chair of BOT, to give you a vote of thanks. Dr. Shah, are you there?
Hi, I'm here. That was a fantastic, very educational, informative talk. I'm actually a bariatric surgeon and do weight loss surgery, and diabetes is one of the main reasons why my patients get weight loss surgery. And talking about the hormonal changes and the neuroregulation receptors such as GLP-1 and the differences and sort of the immediate effects of diabetes on patients who have weight loss surgery and obesity and fatty liver has been very informative, and I was a very fantastic talk. So thank you so much for engaging all the attendees today and for the community of API. And I really appreciate your thoughts today and spending some time with our community.
Thank you very much.
Thank you very much. It's been a pleasure. Thank you very much. Thank you for having me.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.
Thank you so much and have a good night. And thank you again, Dr. Narayan, for that really amazing.
Thank you.
And
anytime. Thank you. Thank you very much. Thank you. Bye-bye.
API can do some endowment of some type, but it's a difficult situation for funding, but we'll do our best. Thank you so much. Have a good day.